that sort of type.
Yeah.
Okay, so Abby, you're now currently, what's your position now?
So I'm the Allied Health Research Advisor at Monash Health in Melbourne. And that role really is about building research culture and capability across all the allied health clinicians, wherever they might be in our organisation.
Even though your origins are speech pathology.
Correct.
Yes,
So I'm proudly flying the speech pathology flag in that
correct.
space.
Yeah.
And I sort of keep my links to speech pathology through some of the research that I do, but also through adjunct positions with both La Trobe University and Monash University as well.
Sure, sure. So when did you finish your PhD?
I had to think about this before before we caught up because I couldn't remember the date, but it was 2016 when I finished, believe it
Right.
or not.
Okay. So that's a few years ago
It
now.
is.
So you had a focus on aphasia in your
I did.
PhD, but particularly in acute setting. So
Mm.
what made you sort of focus on the acute setting?
Well, I was very much at that point in time an acute clinician. It's how I identified, it's where my passion lied or lay, and it's where the question that I had came from, I guess. So I'd been working in an acute neuro type role on an acute stroke unit, doing that sort of work, and I got to the point where I had to make a decision about where to next with my career and was sort of mulling over the different options that were available to me. And to be honest, Linda, research wasn't really on my radar at that point in time. But I did have these niggling questions about my own practice that kept presenting themselves, fairly regularly in my everyday practice. And one patient experience that I had really set me on this path, I guess.
Oh, do you want to tell
Um,
us about that one?
yeah, sure. So I was working with a guy called Peter. He doesn't mind me using his name because I've told this story a couple of times. He was a youngish man. You know, your concept of what's young and old changes a bit when you work in stroke for a little while, who was at sort of the peak of his career, living a really fulfilling life. And he was found on the stairs to his workplace one day having had a catastrophic stroke. So he had a hemiplegia, he had dysphagia, and he also had aphasia. And my role, as I saw it at that time in the acute setting, was very much about getting him eating and drinking again so that I could essentially get him out the door to rehab where he
Yeah.
would get the services that he needed to be able to improve. So I saw my role as being really clearly defined. And I thought that I was working in a really patient and family centered way. So I was going in there and speaking to his partner and his stepdaughter about what Peter's goals might be. And so they sort of said that he loved drinking lattes and he loved eating pasta from this particular place on Brunswick Street, which was near where this hospital was. And so I'd often go in there and I'd talk to Peter and sort of say, you know, we're moving towards that latte, Peter. We're going to get you towards that latte. And one day his partner said to me, Abby, you know, as much as he wants to drink that latte, what he wants more is to be able to tell you that he wants the latte. And it was a bit of a slap in the face, really, because I thought I was doing the right thing here. I thought that I was meeting this family's needs. But I actually hadn't stopped to listen to what their needs were. And it also made me feel a bit uncomfortable because I wasn't sure that I had the skills to provide them with what they wanted. So there were lots of questions in my head around, am I doing the right thing? And
And
I guess I want to, what was that?
I'm sure a lot of clinicians go through the same thing as you, whether they've had a PETA or not. I think that,
Yeah.
it's the time pressure of the acute setting, all of those things. But so you went on to ask some questions in
I
your
did.
PhD.
I
So
did.
what sort of research questions were you asking in your PhD?
I was try as I might to formulate a good quantitative question, as a good acute speech pathologist thinks they should. I kept coming up with questions trying to understand the current pathway for aphasia management in acute settings and try and understand why people made the choices they did in that management pathway. So what was it that was driving speech pathologists to do what they do in terms of the management of aphasia? So that's really the questions that I went into my PhD with. And of course, you go in with one question, and the joy of qualitative research is you come out with a whole lot more. But you also go where the data takes you. So I sort of twisted and turned along the journey.
Yes, and one of your provocative titles was Communication is Taking a Back Seat. So do you want to just start and tell us that story of your PhD? What were your findings really?
So I guess there was sort of three components to my PhD. And the first component was really to get a sense of what is the literature telling us in this space, because as a clinician, I actually didn't have a good sense. So I went and had a look at the literature, but I had a look at it with the lens of thinking, well, what does evidence-based practice mean in this space? What should it look like? And really what I was finding there is that there isn't a lot of information there about how speech pathologists make decisions, what helps them to make decisions, and what factors they need to sort of be balancing up in that decision-making process. So that was sort of what the literature told us, which made me think, right, we're in the right place to be doing some work to actually understand this a little bit more. And that's when we designed this first study. And the first study was really asking speech pathologists, what is it that you do? Tell us about what aphasia management means to you, what it looks like for you. So what happens, when it happens, why it happens. So we interviewed 14 speech pathologists from mostly down the eastern seaboard of Australia, but they were from different states. Some were metropolitan, some were regional, some sitting in the private sector while others sitting in the public sector. And also they had different levels of experience. So we had some who were newly graduated right through to people who'd been practicing for 20 years. So we had this really diverse group of speech pathologists, all of whom were incredibly passionate about the work that they did. They were dedicated speech pathologists. And I went in there, as I said, trying to understand what happened. And so the first paper that came out of that was a really in-depth understanding of that pathway. So what happens, when it happens, why it happens. And what came out of that is perhaps unsurprisingly, but now we've got evidence to tell people, is that there's such diversity in that pathway. So it is to some extent a postcode lottery. Where you turn up on any day dictates the type of service that you would get. So how referrals are made, what assessment, if any, you get, whether therapy is provided, and if it is, what that looks like, the type of education that's provided, and also the advocacy that speech pathologist does. So there's so much diversity in that. And lots of that is shaped by the individual's sort of professional identity.
I see.
Their sense of who they are, what their role is, what they're skilled at.
Yeah.
And so that sort of accounts for some of those differences. But there was this underlying concept, I guess, or construct that speech pathologists in the acute setting are the first contact with the profession. So they set the tone for that relationship. And there's some weight, I guess, that comes
Yeah.
with that responsibility as
Sure.
well. Yeah. But, you know, I went in with a very pragmatic, practical question, right? But as I was asking them, one of the questions that I asked these 14 speech pathologists was, you know, what role does evidence-based practice play in your aphasia management? And Linda, I don't remember I don't know if you remember at the time, but I just describe it as people's faces dropping. So I'd been in these beautiful conversations, these collegial conversations with, you know, mutual respect, mutual understanding, people being very open, and also, I guess, showing some vulnerability in explaining their decision making and their processes. But as soon as I said those words, evidence-based practice, the dynamic shifted. And when I was reflecting on that with you, Linda, and with my other supervisors, Miranda Rose and Robin O'Halloran, we sort of thought we actually need to unpick this a little bit more. We need to understand why the mention of this is like there's a ghost walked into the room or something like that. And what people, when we were able to probe a little bit more and ask a little bit more about this, there was a really big sense of professional dissonance that came out of evidence-based practice. So they felt like evidence-based practice was this benchmark that they were aiming for, but that they couldn't get there. And when you know professionally that you should be somewhere, but there's so much standing in the way of you getting there, gosh, it sits uncomfortably, doesn't it?
Yeah.
And that's, I guess, what they were describing, this real sense of unease that came from that. And as a result, hearing about evidence-based practice was disempowering for lots of these speech pathologists. Instead of giving them energy and giving them direction, it actually felt like they were being criticised and critiqued rather than supported.
Yeah. So in some ways, it doesn't help you with your research question about, you know, decision making. If you're a clinician, you know, deciding what to do with particular patients as they come in, maybe they're saying, well, evidence-based practice just doesn't come into the equation.
Look, I think part of it too, Linda, is people's understanding of what evidence-based practice actually is. So we're often taught, and I think it's changed now. I hope it's changed now. But at universities, the emphasis was very much on what does the research literature tell us? And while that's important, obviously, it's one component of what evidence-based practice is. And what we really need to be doing is integrating different streams of evidence. So what's important to the patient and their families? What does our clinical experience tell us works or doesn't work? And what constraints does the context that we're working in place on the work that we do? So by thinking about evidence-based practice in that more integrated way, I think it gives us space to be able to think in a slightly different way and to understand that research evidence is just one stream of knowledge.
Absolutely. Yeah. And there's actually, you know, in the acute setting, there's not a lot. It's very difficult to do
No.
research in the acute setting. So
Mm-hmm.
I should imagine there's not a lot of research anyhow in the acute setting. Yeah.
There's not a whole lot out there. And certainly when I started this, there was very little. You know, we've seen a little bit of a movement towards that,
Yeah.
particularly here in Australia with Erin
Mhm.
Gadecki's work from Western
Mhm.
Australia. But at that time, there was a real paucity of literature, which in itself, you know,
Yeah.
creates challenges, doesn't it?
Yeah.
Because
Yeah.
what am I aiming for here?
Well, that's right. There are no best practice
That's
guidelines
yeah,
for acute, for
that's
the
right.
acute setting, whether
Mm,
it be for aphasia, dysphagia,
yeah.
dysarthria, the whole raft of disorders that can occur after
And
a stroke.
And I think it's really important you say that, Linda, because, you know, I was looking at aphasia here,
Yeah.
but probably if I was to do this research now, um, it feels a little bit artificial to separate
Mhm.
things out like that because people don't exist as a diagnosis alone or, you know, after a stroke, it's very rare that you'll just have aphasia. You know, aphasia is part of
Mhm.
a constellation of different um,
Mm.
difficulties and strengths that somebody might have following a stroke. So
Absolutely.
I'd probably bring a different lens to it these days.
Yes, but even in your sort of discussions about aphasia management,
Mm,
you brought that conflict
mm,
of, what should I be doing with people with aphasia when I'm so focused
mm,
on dysphagia,
yeah.
and in that sort of very early stage, and in the patient, the family is still in shock, it's
Mm,
traumatic,
mm,
and so what should I be doing?
mm,
So you highlighted, I think, that sort of issue that speech pathologists have, not
mm,
only the conflict on their time and the
mm,
pressure on their time, but also their disconnect with evidence-based practice.
yeah.
And really, researchers haven't really been helping in that sort of regard, perhaps. Do you think have changed? Do you think things have changed a bit since your PhD?
Oh, it's tricky to say, Linda, because I actually didn't go back to clinical practice in the same
Mm.
way as I had been practicing. Um, in large part because I felt that dissonance too. You know, it sort of shone a light
Mhm.
on that emotional response that I was having. I think educationally, I've noticed that there is beginning to be a shift in the way that we talk about aphasia, the way that we think about it, um, and that sort of stepping away from aphasia as an impairment alone, but rather that psychosocial um, impact of it. So I think that that's really important.
Mhm.
Um, and also, I think we're hearing more about the experiences and the voices of people with aphasia. And by goodness, that's powerful.
It
You
is,
know,
isn't it? Yeah.
just stopping as a professional and listening purely because you value that person's perspective. So to me, that's a change that's really useful. But we've also seen changes in our healthcare system
Mhm.
in the last sort of 8 to 10 years, um, where the medical model and the pace of what happens in acute settings has in some ways increased some of the challenges that people were experiencing. And I think um, I don't like to harp on about COVID and the lessons that were learnt, but it really highlighted the challenges for people with any sort of communication disability in the acute hospital setting. Um, and it helped us to be really clear about where those health inequities lie,
Mm. Yeah.
um, and really shone a light on that as well.
Yeah. Yeah. It
Um,
must have. Yeah.
But I wouldn't be surprised if I was to walk back onto the ward today and have a conversation with a speech pathologist that I wouldn't be surprised if they described the same
I
sorts
think
of
so too.
challenges. that
Yes.
that I was experiencing then.
Yes, I agree. And I remember that you did an observational study
I
towards
did.
the end of your
Yeah,
PhD. And I mean, that's always such, I think, a privilege to watch a
absolutely.
speech pathologist, go about their work and things like
Mm.
that. What did you learn from that sort of observation?
So this was a really, oh gosh, it's a beautiful way to do research, I think, because as you said, such a privilege and just provides a really different lens
Mm,
through which we can look at practice. We're
mm,
not relying on the report of people, we're actually watching practice unfold. And so not only did I do observation, but as part of that, I interviewed the people with aphasia, their close others, and the speech pathologist about what this experience was like. And it was, I guess, surprising to me, but also really heartening that what sat at the center of practice for both the patient, the family member, and the speech pathologist was the importance of interaction and relationship. So that emphasis on creating a positive experience.
mm-hmm. Yeah.
So the speech pathologist wanted to create a positive experience for the patient and their families. They wanted them to be positively engaged with speech pathology and with their recovery journey. But equally, the families and the people living with aphasia didn't want to do anything that would make things uncomfortable for the speech pathologist. They wanted them to have a positive experience of them.
Right.
So, they made choices about what they asked for and how they communicated, so that it was mutually a positive
Yeah. They were
experience.
being a good patient.
Yeah, that's right.
Mm, mm,
Yes.
mm.
Um, and despite that, it was
Yeah.
really clear that this cultural context in which this was happening, which is an acute stroke unit, so very much sitting within that medical model, that hierarchical model, and with some significant sort of service requirements in
Mm,
place, the best intentions weren't always able to be realised because there had to be that shift towards sort of tasks and activities and guidelines and KPIs
mm.
that compromised the ability to provide truly, I guess, relationship-centred practice in that
Right.
space. Yeah,
Yeah. 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 That's tough for any clinician, I think, particularly acute clinicians when they know that they
absolutely.
can go on to rehab properly as well.
Yeah.
Um, yeah.
There
So,
was one patient as part of that, Linda, who I interviewed, and he had fairly global aphasia,
mhm,
so very limited verbal output. And I sat down with him just after he'd been discharged from acute and he'd gone to a geriatric evaluation and management unit. And I sat with him for quite some time, and I was feeling really disappointed because it wasn't able, putting all these supports in place. I was doing every piece of supported communication that you could. And I just thought, I am getting nothing here. There's
mhm.
no valuable data here,
Okay.
thinking as a researcher. And as I was about to leave, I just touched his hand to sort of give it a pat and say that I was leaving. And he grabbed my hand and just looked me straight in the eye and said, you you are the one for me. And think as I might that it might be some romantic gesture because I'm just so attractive and good looking, like how could he resist?
Yeah.
I think what he was trying to say, and I've sort of thought about this a lot since, is I sat there and listened to him for an
Yeah.
hour.
Hmm.
And I didn't have any, well, I did have expectations, but he didn't feel any expectations around what should come out of that interaction. And gosh, giving someone the time and space to be listened to is
Yeah.
powerful.
Yeah, yeah, very, very. So going back to that, that's probably relevant back to Peter.
Mm.
So if Peter came onto the ward and you were a clinician now, what would you change?
It's a really good question. I think I've changed a lot since then.
Mhm.
So I would, in answering this, I guess I'm going to say this is the ideal world,
Yeah,
right?
oh
Where,
yeah, absolutely.
yeah, get rid of all those constraints that tell me what I have to do and how many
Yeah,
patients I have to see. But I'm really now thinking about aphasia. I'm moving away from that deficits model to a really strengths-based approach. So I would want to know how Peter is communicating with his family in any way, and how do we capitalize on that? How do we
yeah,
celebrate that? And I'd also be thinking about communication participation right from the beginning.
okay,
So I would want to be thinking, how do I set up this environment to best
okay.
support Peter from day one so
Hmm.
that he is having positive communicative experiences? Because I actually think we, as speech pathologists and other clinicians, can actually act to disable people more than they need to be right at the beginning by reinforcing the deficit model by saying, oh, you know,
Hmm.
you're having trouble. This is
Yeah,
hard for you. Look at
yeah.
everything that's wrong with you.
Hmm.
But if we take time to actually have positive interactions, even if the transaction of that communication isn't strong, positive
No.
interaction is so valuable, and it empowers people in their
Mm.
recovery journey,
Mm.
and in their healthcare. Like, this is a big time for families and for individuals, and
Yeah.
we need to be respectful of that.
Of that, yeah, yeah. Would
Yeah.
you, so your focus with Peter was on lattes. So in terms of, do you think that would have opened up the conversation about communication? Does it also send a bit of a message to him and his family that, your swallowing is more important
Mm.
than your communication? Your communication problems are not really a problem. Uh,
Absolutely. Yeah.
mm,
I think we have an incredible role as speech pathologists that we're not realizing at this point in time, which is to be communication access advocates. So we need to
yeah.
be banging that drum for anyone
Mm,
who'll listen, or even the people who won't, saying
mm,
communication matters from
yeah,
day one,
yeah.
regardless of what somebody's communication disability is.
Mhm,
It's our responsibility as healthcare workers to enable this person to communicate to the best of their ability. And that communication is, it's co-created. There are at least two people in that interaction,
mhm,
and you need to carry some of
mhm,
that responsibility. So I think we have a lot of work to be doing around um, creating communicatively accessible environments within the hospital setting.
mhm, mhm. And it was the family member, was it, that sort
Mm.
of said, um, you know,
It
he wants
was.
to be able to communicate more as
Yeah.
well. It's always difficult. Some speech pathologists in the acute setting say they find it difficult
Mm.
to talk with family. Did you ever
Mhm.
find that, or I guess in Peter's case, no?
Yeah. I think there are challenges that are environmental challenges. So,
Mhm,
people are sharing rooms a lot of the time. They're separated by a curtain. There's beeping in the background. So, finding space that you can actually have what can be a really confronting conversation with people
Mm, mm,
is difficult, yes. And also aligning the time that you're in seeing a patient with the time
mm,
that families want to be there can be difficult as well. And, we talked earlier about some of the challenges of COVID, but that's actually one of the positives that I've observed is
mm.
that we're allowing our workplace in the clinical space to be a bit more flexible. So, sometimes I have seen people, do shifts that start at 10 in the day and go through till 6 or
Uh-huh.
7 at night so that they can capture those families,
Mm,
and do evening mealtime reviews rather than breakfast mealtime reviews. So there's lots of opportunities there to think about how our services and our structures can be redesigned to
mhm.
actually better meet the needs of patients with communication disability and their family members. But the thing for me that's really important in that service redesign is actually saying to people with lived experience, what is it that you wanted or
Yeah,
needed at that
yeah.
point in time?
Mm,
Because we make a lot of assumptions.
we do.
And,
Do.
I think the story of Peter is a really clear example of assumptions that we make as
Mhm.
clinicians, that I made as clinicians. And we we have a responsibility to stop and to listen.
Yes. Yes, yes, and certainly to listen, as you say, and develop that relationship over
Mm,
time.
mm,
But I think your research really highlighted some of the issues, the conflicts that
mm,
speech pathologists who work in stroke units and things like that experiences.
mm.
So thanks very much for that, Abby.
You're
Um,
welcome.
yeah, and I hope that some of the work that you do, I know that some of the work that you've done is being carried throughout the
Hmm.
world. So thank you.
You're
Okay,
welcome.